It's good to see you, Dr. Curigliano. You're talking about all sorts of things. One of the central things here at the conference in Brussels is this concept of heterogeneity of tumours. What have you got to tell us about that from your chat here about challenges in biomarker development and drug development?
Yes, this is a very important question, I believe, because why genome analysis of tumors, of breast cancer tumor samples, permit us to discover that we have different subpopulation within a breast cancer tumor sample. And we have a specific driver mutation that can drive progression of disease, progression also to specific cancer treatment.
And which driver mutations are you talking about?
We are talking about specific driver mutation like PI3K mutation or P53 mutation that are very common in several types of cancer, but specifically in cancer cells. And when we talk about triple negative cancer cells, we can find something like 50% of tumor samples that are mutated for P53.
But heterogeneously...
This is a very important question, because when you compare the tumor sample in the primary breast cancer and in the metastatic site of disease, you can find different subpopulation according to genome-wide analysis. So mutations that you find in the primary tumor are not found in the metastatic site of disease. Why this? Because there is a Darwinian evolution, or because there is an interaction with the stroma?
Okay,
so this is the point.
The cells, the cancer cells, are interacting with the microenvironment.
Absolutely.
And I know that's a special interest of yours, so what have you been able to find out?
This is very important, because we don't understand if metastatic cells have the potential to metastatize within the primary tumor, or if cells that disseminate can change their genomic program within the microenvironment, because we know very well that once you have a tumor, everything changes. The immune system will give a response. In the bone, you can find cytokeratin positive cells. Also in healthily control, we listen this morning. So we are sure that once the tumor cell is in the bone or in the brain or in the liver, we'll adapt the genomic program to that specific microenvironment, because microenvironment can modify the cancer program of the cell.
Of course, now you need tools with which to probe the microenvironment and to assess the interactions. You then need treatments which are appropriate. So first of all, the tools, what have you got and what have you found? Okay,
emerging tools that have been presented this morning are research of circulating tumor cells or bone cells. This is a very important topic, because you can characterize a tumor just with the analysis of a single cancer cells. It was very exciting to listen this morning to a presentation in which you can perform a wide genome analysis on a single cell that can be isolated from blood or from a bone biopsy. This is a very important topic, because in the future, I believe we can really improve our capability to detect metastatic cells.
In the future, how far has it got so far?
Oh, we cannot quantify the future, of course. It depends on the evolution of technologies.
Right.
Actually, this is just research.
So this is exciting developments, but now what potential difference might that make in terms of therapies? Are there available therapies which could influence all of the interactions and the development of the metastatic process?
This is a very good question, because if you identify specific genomic alteration, specific mutations, and you can demonstrate that these mutations are drivers in a xenograft model, you can develop new drugs. So just talk about the presentation of this morning. We know that P53 is mutated in 50 to 70% of triple negative breast cancer. So we can understand that P53 maybe is a driver. And so you can modulate intracellular level of P53 with drugs. And there is a special drug that is, the name is Natlin, that is an MDM2 inhibitors. MDM2 can modulate the intracellular level of P53. So if you block MDM2, you upregulate P53 and you can induce apoptosis in cancer cells. So if you understand that another driver is PIK3CA mutation, you can study specific tyrosine kinase inhibitors that can target PIK3CA, and so you can develop new drug and you can develop new trials. So that's why genome analysis can drive research with new therapeutic agents in the way of personalized medicine. And it will be important to do serial biopsy, because you asked me about metastatic disease. So you treat patients according to progression, redefining the molecular portrait of the metastatic disease and choosing new agent according to the new drivers.
One of the recent historical facts of this whole area is that the more you discover, the more complex it often seems to be. Do you see a clarification? Because I know targeted agents, the sorts of molecular agents you're hinting at,
yes,
are the ideal solution, but there have been disappointments, haven't there?
I believe that there is a network. We are not talking about a specific mutation that in a clonal evolution will drive the proliferation of all the tumors. We know that every time we target a pathway, there will be an upregulation of another pathway. So we need to think about cancer and genomic portrait of cancer like a network of several pathways. And the more you understand about cancer, the more is complex the way to treat it. So maybe the dual targeting can be an option to treat specific subpopulation of patients. But I am sure that if we believe that we have a genome remodeling during progression of cancer, we are going back to the Darwin evolution theory, in which tumor will adapt once he progressed. And so you need every time to understand better what is happening and to develop new agents. The metastatic disease is a chronic disease. And what we need to understand is that in this patient we need to improve quality of life, since this is a chronic disease.
But you need also to conduct the orchestra of the metastatic process.
Absolutely.
So do you see any emerging insights into how to do that?
Oh, I just believe that in the future we will better understand this with next generation sequencing studies. Because if you believe that any site of metastatic disease have a different genomic portrait. There was a beautiful paper on New England some weeks ago. It's on kidney cancer, but anyway, if you characterize the liver mets or the bone mets or the lung mets, there are different diseases. So in the future, maybe we need to treat patients, driving treatment according to the biology of the single site of disease. So we have within the metastatic disease different diseases. And
the cancer doctor working on a day-to-day basis should take out from this what sort of messages? Oh, the messages is this is research. But I am sure that in the future, when we will have lower cost of these technologies, it will be possible that the patient will arrive in your visit, in your clinical visit, and will give to you maybe the circus plot of the tumor with a wide genome analysis, and so you will discuss with her, okay, we can do these targeted agents or these other targeted agents. And I believe that this future is close to us, absolutely. Giuseppe, thank you very much for joining us.
You're welcome, thank you.